Najarian. He is a professor of computational medicine, bioinformatics, emergency medicine, electrical engineering at the University of Michigan. And he's going to give us what sounds like a very interesting talk on artificial intelligence and machine learning for quantitative diagnosis and prognosis of traumatic brain injury. We really appreciate you coming and taking the time to speak with us, and look forward to your talk. Thank you.
Thank you very much for the introduction, and thank you for inviting me to share my work with you guys. I look forward to interactions about what can be done in projects similar to that. As a starting point, I have to disclose some financial interest in companies that I've been involved in. None of the technologies that I'm talking today have been approved by FDA or used in clinical setting. And with that, I can tell you a little bit about our lab. My lab is called Biomedical and Clinical Informatics Lab, and it has a number of around 30-something people on the computational side and maybe 15, 16 people on the clinical side. The people on the computational side, they're coming from different disciplines like mathematics, electrical engineering, computer science, computer engineering, biomedical engineering, people who are trained to work with mathematical algorithms and engineering tools. And on the other side, as you see, we have a number of clinicians from different disciplines. We have cardiologists, radiologists, anesthesiologists, neurosurgeons, emergency medicine physicians, people with the expertise in the domain and clinical domain. And what we do in our lab is essentially we identify clinical problems that are complicated, and if they're at least partially solved, they will have an impact in the field. And what we do, we form a group of people from the two disciplines like computational and clinical, and we go after the solutions. My lab also is involved in a national center that we are basically hosting here at the University of Michigan. It's called Center for Data-Driven Drug Design and Treatment Assessment. I will say a little bit about that at the end of my presentation and description of some of the techniques that we do. So our essential, our philosophy in the lab is to focus on solving the problem, creating solutions as opposed to just publication. And because of that, we work very closely with industry partners, and majority, I would say 60–70% of what we do in the lab at one point or another gets licensed to companies that bring these solutions to the bedside. So I will have to acknowledge the work of people who have done in the lab and the collaborators who have helped us design these things as solutions for the clinical setting. My lab has 35 active members on the computational side, as I said, 21 faculty partners involved in it, and I would say 15 of them are clinical faculties. And we have been working on creating artificial intelligence solutions for traumatic brain injuries for many years, and probably a number of patents, maybe 40, 50 patents that are focused on designing computer-aided decision support systems. So with that introduction, I want to tell you a little bit about our research on TBI. I have divided our work in the field into three different categories. One is patient outcome prediction that focuses on using artificial intelligence for estimation of short-term and long-term impact of TBI on people. Then designing AI solutions to identify and quantify the injury and segment the abnormalities, identify and segment abnormalities in images, and specifically I will talk about the work that we have done and estimation of ICP and methodologies that we're using for that. At the end of this discussion, I will tell you a little bit about, how we have created new algorithms for integration of the information coming from different fields. And that's like, something that comes towards the end. So I'm going to start with patient outcome prediction. As I mentioned, we're going to focus on short-term outcome prediction. And these are essentially techniques that will tell you what's going to happen to the patient, like a survival versus death, or if they're leaving the ICU to home or rehab. And these techniques basically focus on not very detailed information that we captured from the patient. So this is one of the first sort of work that we did in the field, and the focus was to look at the EHR type of data, not including the images, just looking at what we know in EHR and try to predict what's going to happen to the patient, how many days they will be in ICU, and where they go after the ICU. So that I consider that like a very quick sort of assessment that can happen based on the information available at the time of, like, within the first hour of admission to the hospital. Then we focus on long-term outcome, and I'll show you a few of the slides that are focusing on the long-term outcome. And the way that we define long-term impact of TBI, we have been in discussion with so many people, how do we quantify that? So eventually we look at GOSE and we try to estimate GOSE or binarize it, like, put a threshold in the middle and say, like, if it's like beyond a certain threshold, it's worse. It's just like, and below that, that's a different category. So often, most of the time, we will have to either consider GOSE to create a binary situation, good outcome, bad outcome, and sometimes we actually treated that as, and I will show some of the results there, that we try to do regression and estimate the exact GOSE value. So one of the work that we've done in the past is essentially, look at all the information that we know about the patient and try to predict what would be the range of GOSE 6 months after admission to the hospital. So after we did this work, we realized that majority of the techniques that people create using artificial intelligence these days, as you know, they're based on methodologies such as deep learning that are not truly transparent. So it would be not the best option to go to you guys and say that, like, I have a model, nobody knows what is happening inside this model. There's a bunch of mathematical technique, like, methods, equations interacting with each other. And these mathematical technique here are telling me that the patient is not going to do well, like in 6 months or something. There's not enough justification for like, trusting a mathematical method that nobody knows what is happening inside it. And because of that, we went to, like, address this challenge of black box machine learning algorithm that don't have any interpretability. Like, you have to trust them for what they say and not know why they're making a prediction that they're predicting. We have encountered this problem multiple times in the past, dealing with different clinical applications. And like I said, like, we have a lot of work focused on different things in cardiology, like heart failure kind of work. So it happened that when we were working on heart failure at the time, we discussed, like, we worked with National Science Foundation to create a new machine learning algorithm that is not only acting like these neural networks that we're familiar with, but also they're completely transparent and you can see what is happening inside them. So I'm gonna read the name for you, but the name is, like, it's just like a sort of a bunch of buzzwords in it. So It's called tropical geometry-based fuzzy neural networks. So let me start with neural networks. We're familiar with neural networks. They're essentially the core idea of all kinds of machine learning, most types of machine learning. Fuzzy neural networks are the ones that are neural networks that can be interpreted in terms of rules, in terms of approximate rules. So far we are approaching what we want to do, but the problem was that historically there was technical issues. There were a bunch of important technical issues implementing fuzzy neural networks. And what we did, we went to a field called tropical geometry, an emerging field of mathematics, and we used some capabilities coming from tropical geometry to address the technical problem people had with fuzzy neural networks. So now, let's put all of that together again, like tropical geometry-based fuzzy neural networks. It means that neural networks that are completely interpretable, like the humankind rules involved in it, and they're made technically efficient and tractable using tropical geometry. So we started developing that, like I said, for applications that we were doing for heart failure. So I'm gonna explain the problem first in heart failure, then I get to TBI, because it's probably easier to tell you how we started developing that, and then once we develop that for heart failure, we kind of customize it and apply that to TBI. So going to heart failure problem, people who were diagnosed with heart failure problem, there was always like the question of, are we going to continue doing medication with them, or like move them to LVAD or like heart transplant at certain points. So we divided heart transplant and mechanical devices into advanced therapy. And the question that we were trying to answer for cardiologists was that we are monitoring a patient at any given time, and then we make a prediction whether the person has to go to advanced therapy like LVAD or heart transplant, or we continue doing medication. So we created a binary sort of decision making, but as you know, like, deciding who gets the next available heart is not something that you want to leave the decision to like a completely opaque, like, black box kind of machine learning algorithm. You need to know why the algorithm is predicting or making a decision to go like give this heart to this person as opposed to that person. That was the sensitivity of that decision that forced us to create this algorithm originally. So, so we created the algorithm. We applied that to the data from University of Michigan Health System. So we wanted to do two things. One is to make sure that this algorithm is not, it's on par with other algorithms. You cannot make too much compromises to say like, I have a transparent machine learning algorithm, but its performance is much less than the rest of them. So it's not like justified, it's saying that you are compromising accuracy for transparency. So all I want to go in here, like, show you in here is that when we look at the metrics like AUC, EUCPR, F1 score, and other factors, you see that what we have in here for this algorithm, and I explain them later on, the performance that we get this algorithm is completely on par with other techniques, actually superior to things like logistic regression, EBM, support vector machine, and even XGBoost. It's on par when you look at like, standard deviation with the most sophisticated techniques like random forest and XGBoost, but at the same time, it's in the same range and sometimes even better, which is check mark number one. But so it means that you can have a transparent model, but do not compromise on the accuracy. So now I want to go back to the concept of what we mean by saying transparent when we're describing this, like, family of neural networks, this family of machine learning method. First observation is that if they make a prediction they will tell you the exact rule or rules that they use to make that prediction. So they say that, like, I suggested that we do, like, advanced therapy for this patient. It's because this, like, the age of the person is high, like this is low, this is like in this range, and so on and so forth. So it will create a bunch of if clauses that say, like, if this is the case and if that is the case, then we make that decision, which is completely aligned with the way human thinks, right? We're not showing you any equation. We're just saying that this is like it's just this factor is too low, this factor is too high, and so on. And because of that, we make a decision to do that. So that's one capability of these techniques, that make a decision, but they provide justification, logical justification for the prediction. Second thing is that, and I would say this is a very significant factor, and I will show that in here, is that when we are working with regular neural networks, machine learning, we start by initializing them randomly. So you have, like, a few million parameters, for instance, and you want to use a set of known cases in the past. We call them training data, to optimize this model, to find the right set of parameters of the model. But we have to essentially start from randomness, which is 99% of the time what we do with neural network. But that 1% is here, that we don't need to start from random. In this case, as you see, I have two columns. Column one, like you see, random initialization, when we're talking about proposed network, is the one that we, just like any other machine learning technique, neural network, we started from random initialization, and you see the numbers that you get. But then with this technique, we have the ability to initialize the network, the model, with the knowledge provided by the clinicians. As a matter of fact, we interviewed a number of clinicians, like cardiologists that are involved in like focusing on heart failure. And we told them, tell us how you make a decision. Like, what are the main rules that you consider when you make a decision about heart transplant versus like medication? And they told us a bunch of, like, saying, I look at this, if this is high, this is low, whatever. We get that information, and that capability, the unique capability of this algorithm, is that you can interview clinicians, get the results, get the rules that they have, and directly use that to initialize the neural network. So as you see, like with random initialization, for instance, like AUCPR is like 56%, but if you initialize it with the rules that clinicians provide to you, you get a significant improvement in that. Not only, like, the value of the metric, the mean will go up significantly, but also standard deviation goes down. It's like it's telling you that majority of the machine learning algorithms that we are dealing with, they're wasting the domain knowledge that is already available, right? We are not trying to replace the clinician. We want to enhance their capability. So why not get them to tell us what is it that they do, the mindset that they have in this, and use it to enhance and initialize these networks. So having said that, let me show you some of the rules that we're talking about. So this algorithm, when you train it, it gives you a bunch of rules. For instance, rule A is that if blood pressure is low and BNP increases, then patient is eligible for advanced therapy. And you have like a number of rules like that are all essentially completely transparent, and clinicians can understand why this is the case for like decision making. So any new patient shows up and a prediction is made, you will see that, for instance, it will say rule A and D were ignited for this patient. That is why we make a decision about that. So with this thing created for heart failure, then let's get back to our discussion. We went to traumatic brain injury, and we looked at the factors that are used in traumatic brain injury. And we created a set of rules, like the same kind of model for interpretable neural network for prediction of the outcome for TBI. And again, we look at GOSC at 6 months. So if you look at, for instance, like I want you to look at this and interpret it like that. If you look at the last column in here, like the third column in here, there is a rule that says that if subdural hematoma is high, there's a lot of subdural hematoma. So that's one. And if the age of the person is relatively high, the person is up. And these high and low, they have like definitions. Like I don't get to the details, but they have definitions created by this. So it says if the subdural hematoma is high and the age of the person is high, we will say that this person will probably need like they will have like not very good outcome after 6 months. So same thing with the rest of the rules. Like we have 3 rules in here, and each one of them not only tells you the logical relationship between the variables with respect to the outcome, but also shows the relative importance of these variables. So in this rule that we saw, it says age is more important than subdural hematoma, and the same thing in here. So we created these rules and we created the algorithm, and the AUC of that was almost 80%, which is also like something that we felt that would justify it to be like something making a useful prediction. So we talked about short and long-term outcome. Let's talk about quantitative assessment of the injury. So first thing is assessment of acute hematoma and segmentation of that. So we created image processing AI techniques to look at the CT of the person and in an automated fashion identify where the hematoma is there. So if you look at this CT, this is the original. Do you see my cursor? I'm referring to my cursor without verifying that you actually see that. Do you see the cursor moving in here?
Yeah, we can see it.
Okay, good. So this is the original CTs, and these are the annotations that clinicians have created for us. And like, you know, and I have to thank all the clinicians that like, you know, Dr. Williamson and others who spent a ton of time like going over like a number of CTs and creating these annotations. So this is the original CT, this is the annotation, and this is what the algorithm creates for us. And you see that these are very similar to the ground truth annotations that clinicians have done for us. We compare it with other techniques to show that our technique like doesn't create too many false positives. You see, like this is a famous algorithm out there called UNet that creates so many false negatives that do not exist in the data. But our technique is sort of more towards making the right prediction of where the hematoma is. So that was for the acute cases. We also look at more chronic cases, looking at subdural hematoma. And again, if you look at these cases, this is the ground truth created by clinicians, and these are essentially the algorithm predicting the presence of subdural hematoma, which is very close. In many cases, we get like, you know, dice of 80%. Dice a metric that we use for segmentation that says that you are segmenting what has to be segmented, but you're not over segmenting and not getting like, you know, false positives. So it's sort of like an F1 score metric in image processing. But so that's one way of measuring whether we're doing the right sort of segmentation, which is at pixel level. It's like, you know, every point of the CT. But then often the clinicians that we're working with, they identify like a threshold, saying that if the threshold is a little bit is in higher than that, we say that there is subdural hematoma, but if it's less than that, it's not clinically important. So we went with that threshold, and with that, the algorithm can get 98%, above 98% F1 score to say whether there is significant amount of hematoma there or not. So now the next topic that I want to talk about is sort of what we did in injury quantification and segmentation will play into this this part, which is assessment of an estimation of intracranial pressure. So we started with the CT and we looked at deformations caused by injury in the CT to quantify that and relate it to ICP. For instance, like we looked at calculated midline shift, we identified the ventricles, the location of the ventricles, and the shifting of ventricles because of the injury, and we quantitatively with very high accuracy we like estimate the midline shift, but also we look at hematoma estimation that I showed you in the previous slide, and we have some technique that look at the edema, presence of edema, and volumetric assessment of edema, and we get all of these quantitative measures that are coming from all over like the CT, combine it with some demographics and injury scores, and combined with that, we try to predict whether the ICP is elevated or not. In this study, we put the ICP elevation like, being around above 12 millimeter mercury. In other studies, we went for 15 or whatever. Whenever physicians change that threshold, we have to retrain the algorithm. So it shows that with relatively high percentage, it will estimate whether the ICP is elevated or not. Like, so before, a sensor is placed inside the brain, we have an estimation of where the range of ICP is. And we enhance that technique, the approach, by adding more features and more mathematical technique. And we use that for both like binary estimation of ICP, like 15 millimeter mercury as the threshold as opposed to 12. And also we did regression of ICP. Instead of saying whether it's elevated or not, we just try to estimate the actual value of ICP. And we had a mean square error, mean absolute error of 4.25, which means like within the same range that you want to call this elevated or not. So the issue was that, so we're working with US Army and other Department of Defense and other entities that are interested in this problem. And the issue was that, especially in military setting, it is not very realistic to assume that you have access to a CT especially at early stages of the injury. So the question that they asked us was, can you have apply this AI on some technology that is portable and can be made available at let's say it's a battlefield or whatever, or in a rural area at the point that you distance from the next hospital with this CT facilities may not be, so you have to make it estimation very quickly at the site of accident. So what we did, we worked with the group that are using an ultrasonic system, an ultrasound system, to put it essentially on the eye and have an estimation of the optic nerve sheath diameter. And the reason for that is previous studies have shown that there is a clear correlation between this diameter of the sheath and the ICP. And the reason for that is understandable that you have an almost closed sort of box in the head. And if if there is accumulation of blood or anything inside the head, it will push, put pressure on the only opening that you have, which is the eye. So physically, there is some justification to say that this diameter will change according to ICP. So there should be some level of correlation. So what we did, we looked at a database of these measurements with handheld ultrasound devices. And we tried to use we created an algorithm to actually identify the diameter, and we correlate that diameter to ICP, and we find very good correlation, very good IUC of predicting just estimating ICP based on this automated method of estimating the optic nerve sheath diameter. So that was really good for like from computational point of view. However, after we did that, we realized that, we did a larger sort of study, and we asked people to use this device to repeat our work. The algorithm is like not affected by that, but the issue was that, the dexterity and the skill level of capturing these images, actually these videos, was very much dependent on the person who was doing that. So the operator factors in capturing reliable images was a major factor that, like, we realized that, the hardware of this technology has to evolve a little bit more before we can be sort of we can rely on the AI to fix the problem for us. If there's a lot of variation in the way that they capture the image, there's not much AI can do to handle that. So we felt that maybe the next move for us, and that's an ongoing project in my lab, is to now create like both of them, look at the CT and look at this ultrasound together, and try to somehow guide the process of like an estimation of ICP using a combination of the two. I'm not going to go into details of this because like this is an ongoing and project, and I don't have results to show for that. Next thing that I'm going to do, and that's the last thing I'm going to cover today, is like, how to use tensors for machine learning. And the idea of tensors like being, vectors are one-dimensional tensors, images are two-dimensional vectors, and if you have like a cubical measurement like CT, they are three-dimensional tensors. And the question is, why we need to have tensor for machine learning and TBI in particular, as I get back to that later on. And the reason I'm going to show it with first with a presentation. If you look at this, like, sequence of like boxes, like white and black boxes in here, there's the continuation. I couldn't put all of that in one row. Can you tell me what is it that we're looking for? And I know you can't, because like, this is what I did. I got letter A, that it's very clear to you at this point that this is letter A, but I got row by row and I concatenated them on top of each other, right after each other. So what I did in simple words is that I have a system, I have a data that has a 2D structure, but in order to, like, what I did, why I flattened the data, and now I ask you, what is the data? And you couldn't say that because by flattening the data, but I destroyed the main information in the data, which is the structure. With the structure, like 2D structure, this is letter A, but if I flatten the data, it becomes something that nobody knows what it is. And unfortunately, this is exactly what we've been doing in majority of the cases in machine learning. So data that we get from the clinical point of view, they have structure, like electrocardiogram, blood pressure, PPG, all of them, they have meanings in relation to each other. But if you get like one of them, look at only one of them to make a decision, and then look at like another one later on, and so on and so forth, that doesn't give you a lot of like, it misrepresenting the data. The data that has a 2D structure, if it's explained in 1D, it's basically the information is missing. So we've been using a ton of like tensor method techniques that we have created for all kinds of applications in health. I'm going to describe the technique by talking about drug-target interaction, estimation of the interaction between drug and target. But I will say that, like, we're using the exact algorithm for TBI. It's an ongoing project in our lab. But I want to just explain the algorithm using this like example, like just like I use heart failure for the other technique. So let's say we are trying to identify interaction between drugs and targets. And many drugs are tested only against a few targets, and many targets are tested only against a few drugs. In other words, like if you make a matrix of drug and target interaction, this matrix will be very, very sparse. Like we have like we have tested in the lab only interaction between some drugs and some targets. But when it comes to drug repositioning and repurposing, the main idea, the step one of drug design, is to see that if the drugs that we know will have an interaction with the target that we want to explore. So estimating interaction between drugs and targets is very important. It's the main step of like drug design. So you can think of that mathematically as we have a matrix of drug target interaction. That's a matrix. And our objective is to complete this matrix, to use the ones that we know to estimate everything else that we do not know. And this is not a new problem. I think you have heard of the Netscape problem that was like, you know, movies versus peoples, and they want to say who would be interested in what movies or something like that. They had a very large, very sparse matrix, and they wanted to complete that. So that's not new. There are so many techniques for this. We call them matrix completion method. There are a number of matrix completion methods. But what we realize is that in reality, this is the matrix that you want to complete. But in reality, you have other auxiliary information. This auxiliary information is in form of interaction and similarities between the drugs. We know that drugs, for instance, from the 3D structure, they have similarity with each other. And this auxiliary information should enable us to, like, you know, complete this matrix more sort of accurately. The same thing with the target. If the targets are proteins, we have like the different types of protein-protein interaction, PPI matrices, that shows the similarities and interaction of the proteins with each other. So now, again, the target is to complete this one, to predict the interaction between drugs and targets. But we should systematically incorporate the knowledge that we have about like this auxiliary information into that. As a matter of fact, we realize that, you know, there is not a single unique way of looking at similarity between drugs. We can look at, like, you know, toxicity, you can look at 3D structure, you can look at so many things. Same thing with the target. In reality, instead of coupled matrix completion of this, considering these coupled matrices, we are doing a matrix completion based on a tensor of that. Like, there are so many ways of looking at similarity between drugs. There are many matrices in here. Same thing with the target. So we are actually completing this matrix, considering these tensors that are available to us. And that goes to the concept of tensor that I mentioned. We created algorithms for that, and we applied that to, like, you know, drug repurposing, repositioning problem. And as you can see, we get, like, compared to other techniques, our technique gets like significant improvement, like sometimes 10 to 15% improvement, which is understandable. We are systematically and algebraically incorporating the auxiliary information into the process. And I show you here that systematically, as you add more information, the system gets better. Like, if you have just matrix completion, you get some value, like, you know, like the mean of AUC is this. But if you add additional information, it will go higher. Additional information being, like, you know, a couple of matrices on drug. And now if you have a couple of matrices on target, it goes even higher. It gets like a bigger AUC. So this is the process that we're now using for TBI and other diseases, that we want to systematically incorporate auxiliary information and additional knowledge that we have to say for what is the best treatment for a given patient. So it's now we're talking about patient versus treatment or medication or whatever, and then use all other auxiliary information in form of tensors that are influencing this completion process. So that was what I wanted to cover, and I think we have some time for questions, if I'm not mistaken.
That was excellent. Thank you very much. I'm going to ask you a couple of questions. For your models, what sort of external validation have you been doing?
That's a very good question. We have, let's say, computational validation and we have clinical validation that we use. For computational validation, we use cross-validation technique with holdout sets for testing. In other words, we do training inside the loop of validation, cross-validation. We always leave some data out and we train and test against that. And then once we see the consistency of the algorithm, we go to the holdout set. And on that set, testing set, we will apply the algorithm without any like prior assumption or anything and see what the results are. But those are computational validation. We always do clinical validations as well. So when the algorithm is actually working and computationally, we give it a check mark. We go to clinical collaborators and we we show them the result of that on different patient scenarios, and we ask them to say, one, do you see any contradictory thing in there? Two, are we doing obvious things or not? Because like if I create an algorithm that says if the person doesn't have a pulse, doesn't have pressure, they're not breathing for 10 minutes or whatever, and the algorithm says the person is dead, I mean, the algorithm is 100% correct, but 100% useless, right? So we check for whether the things that are created are too obvious and are not helping with like in clinical settings. So we always go for anything towards that goal. So for all the TBI cases, we present, in the end, we present the predictions and estimations by the algorithm to clinical collaborators and tell them, like, assess whether the algorithm is doing something reasonable and reliable.
Great. And how are you handling withdrawal of care in your estimations? To what extent are you modeling clinician behavior?
That's a very good question again. I didn't get the time to talk about a type of machine learning called learning with privileged information, that it will incorporate things that happen throughout the process, like, measurements that we're not available at this time, like, we want to make a decision, but that measurement, like that image or whatever, is not available. Or something happened to the patient, like withdrawal or something that happens that we don't know is about to happen. So I know it's very difficult to explain it like in one word, but this learning with privileged information allows you to incorporate the possibility of things that are happening like that and train an algorithm that is at least based on the training information that you provided to that during the training phase. It's informed of those events that can happen in throughout the process. I know that's not an answer to your question, but it's just like a table of contents for things that we're doing to deal with that problem.
Question: the machine has to be taught, and it's taught often by experience. But the experience, as Patrick suggested, could be tainted by withdrawal support at different parameters. Or one of the basic things is you need somebody to evaluate the relative value of each of those parameters. And we know in medicine that those are often hotly debated. How do you solve that? Who are your experts? Are they machines or are they people?
For the most part, we are adding to the debate to say, like, now you have like the expert, the clinician who's making this decision or determination, identifying the main factors, and we have the algorithm to do that. So we certainly, with the quantitative techniques that we have, we can always identify the major factors at any given point and highlight the importance of these factors in the recommendations that the algorithm is making. We can quantitatively say that. However, that doesn't mean that that's the reality, because these algorithms can be easily fooled by statistical challenges and variations that we get in the data. That is why we always call these like recommendations or observations that go to clinicians. We don't, none of these techniques has any claim in the direction of saying that what they're saying is the reality. We just like make an observation presented to clinicians. So that in the end, the clinician is the person who makes the determination whether like these things are real or not. Just think of these clinical decision support systems as like put them in parallel to like, you know, what you get from the CT and MRI. Looking at the exact data collected by MRI is not very informative. So you have algorithms to analyze that and make like a visualization of that. Is this visualization exactly what is happening in the like person's head? Not necessarily, but it's some summarization, like, you know, abstraction of what is happening in there, so that clinician looking at that make a determination. Our techniques are also like that. We're saying we have a ton of raw data that like, you know, may not be easy to analyze all of them at once. We analyze them, we identify the factors that are important at any given point and make suggestions. But then it's entirely clinician's decision what to do with this data.
Thank you very much. It's a brave new world and a good one, but it's important that we figure out how these are incorporated into our clinical practice and how they add value. Much
Absolutely.
appreciated.
I completely agree. I mean, sometimes like, you know, engineers and like, you know, companies in particular, they go too far by, you know, basically presenting these as that this is reality. I can tell you the reason that there aren't many FDA approved technologies like that is exactly because of that. They like majority of these techniques do not consider all other factors that can influence this decision. So that's why clinician has to be supervising all of these steps.
Thank you so much for spending the time with us today. It's very enlightening. Much appreciated. Thank you.
Thank you for inviting me. Have a nice day.